Morning, and thank you for the lovely introduction. As you can tell, I'm Kelly Gebo, and I'm not Eric Dishman, who was supposed to give this talk. Eric received a subpoena or summons to come for jury duty, and in an effort to keep him from going to jail, he is not here in Iceland, and he's very sad to miss it. However, he's going to report for jury duty today. So I am here on his behalf, and I really appreciate the invitation to speak with you. I'd really like to talk a little bit about the All of Us study and how we are potentially innovating in health cohorts and research, and really look to you for all of your expertise and all the work you have done. In the next 10 minutes, I'd like to give a little bit of an update on All of Us and where we stand as a research program, with thanks to many of the people who have provided lots of the infrastructure and actually some of the slides that have helped with this presentation. I'm relatively new to the program and have joined this fall, and I'm keen to learn in the next 24 hours from all of you and the experience you have had with your cohorts. So the All of Us research program is unique in that it's diverse, and we are trying to achieve extreme diversity and looking at approximately 1 million people or more. We are trying to be longitudinal with the ability to recontact our participants over the next 10 years. And we're collecting data from a wide variety of types of resources, both electronic health records, surveys, we're doing a baseline physical evaluation, and we're also obtaining biospecimens. And then, as we were talking about just recently, we're engaging with our participants as partners. So they're really engaged not only as people who are donating their health information, but as people who are helping with governing the process and helping us think through data privacy and what are the questions they would like to answer as both parts of our scientific committee and a wide variety of our other governance organizations. And then finally, while we're nationally a study that's looking across the US, we are open to all researchers. And we're going to have open software and tools that are going to be available to anyone to be able to look at our data. So in terms of the AoU protocol, we have 2 ways that participants can enroll in our study, either through direct volunteering, where they engage through their phones or app on their web-based system, or through our healthcare organizations. So participants can engage through the healthcare organizations that they are actually receiving their healthcare at. They enroll and consent online. I'm sorry, I can't tell where the arrow is. You can't see it. So they enroll and consent online, and then they do 3 health surveys, and then they're invited in. So people who are participating are given, who all do the 3 health surveys, then provide baseline measurements. They're invited for biospecimens, and then we are engaging with smartphones and wearables in the future. We have a large variety of healthcare organizations that are helping us with this, both through our direct volunteer network as well as our HPO network, and a number of community partners across the United States who are helping us with engaging diverse participants to enroll in this study. The survey modules that we're doing to start with are 3 basic ones. They're called the basics, overall health, and lifestyle. After an interval of approximately 3 to 6 months, people are then given 3 additional surveys on personal health history, family health history, and healthcare utilization. There are additional surveys that are currently in development, and we hope to roll those out in the near future. In addition, at baseline, we obtain physical measurements, and those are obtained in the clinics through our nursing staff, and those are blood pressure. We calculate BMI, heart rate, height, hip and waist circumference, and weight. Biospecimens are also obtained. We obtain blood, and when this is not available, saliva. We also obtain urine. Our participants will also have access to their physical measurements through both their web-based app, as well as being handed their results in writing. In addition, we're obtaining mobile health data. We have a Bring Your Own Device program that we've established with Fitbit now. We are trying to establish relationships with a few other organizations. We have over 3,000 people who are sharing their Fitbit data within the past 3 weeks. So we have very exciting data that we're very thrilled with, and we're beginning the pilots of other specific devices. Our scientific committee has developed a framework, and many like you we are developing a platform which is going to enable researchers to do research. So unlike some traditional cohorts which studied a disease-specific cohort and then had research questions along with it, we are trying to facilitate research in a wide variety of disease-agnostic ways. So through this, we have developed 5 principles. We are trying to enable research that will increase wellness and resilience and promote healthy living. We're trying to reduce health disparities and improve health equity, particularly in our underrepresented and biomedical research populations. We want to develop improved risk assessment and prevention strategies to preempt disease, provide earlier and more accurate diagnosis to decrease illness burden, and improve health outcomes through reducing disease impact through improved treatment. What we're trying to do is to develop ways to look at specific topics in a disease-agnostic way. So this is an example within opioids, how we would have 5 potential research questions in all of the parts of our framework. And this could be done within cardiovascular disease or cancer or wellness or a wide variety of other topics. So where do we stand now? We had our national launch approximately a year ago, and we have over 133,000 participants who have completed the full protocol from all 50 states. We have over 100 partners and 300 clinics who are currently enrolling, and we plan to expand that in the near future. We have a bilingual enrollment website, and our participant portal and app and call center are all bilingual. We have a biobank that's been established, and we've received over 1 million specimens. And we have a 24-hour shipping process with a capacity for over 35 million vials. We've developed an interactive mobile exhibit that travels across the country and has visited nearly all of the states. So this is some of our beginning data, and this is how our sample has increased over the years since we began enrolling. The red line shows all of the participants who have contributed survey data as well as their demographics. The blue line is people who have completed all parts of the study, so people who have engaged not only in the surveys, but also in the biospecimens and physical measurements. We have a broad, diverse cohort, and over 50% of our people are racial and ethnic diversity with a wide variety of different groups. And in terms of gender identity, we also have over half of our population being women, but we have a very large group of sexual and gender minorities represented as well. Over 75% of our population is what we would consider to be underrepresented in biomedical research. So in terms of our goals for 2019 and 2020, we have a public data browser which is coming soon, which will allow all of you to see what data has been collected and to see how people are how our population is and how we are expanding in the coming months as we continue to enroll. We're beginning our genomics with both GWAS and whole genome sequencing. We're going to try to return results, and so we have a pilot which is going to be launched this year in terms of getting participants back some of their data. They can actually get their survey data back currently, and we're planning to begin to enrolling this out with some of our other data that we're collecting. In addition, we're facilitating researcher engagement. We have a scientific roadshow where we're going to be launching our platform, and we're going to be talking about how our platform can be used in a wide variety of conditions. And we're going to be launching our researcher workbench, where all of you are going to be able to engage in looking at our data, and we hope to have this later this year. As was discussed recently, we have a number of current challenges. We're thinking about how we're going to be doing data sharing and matching to publicly available databases. Obviously, we want to be able to look at the National Death Index and other cohort data. There are obviously issues with doing this, both in terms of IRBs as well as logistical limitations. How to design our protocol and select variables in a disease-agnostic study. Allowing open access to all, and how to enable maximum science for this. We really want to enable as much science as possible, but also want to limit bad actors. We want to make sure that we are doing this in a responsible way. How we can return results, and how we keep people interacted and wanting to participate in our study over the next 10 to 15 years. So I look forward to the next 24 hours and having the opportunity to discuss these and other important questions with all of you. As we sort of say, it takes all of us. There's a large group of people who I'm standing here representing, some of which are shown in this picture. But I thank you for the opportunity and welcome any questions you may have, either about our program or some of the challenges we're facing. So thank you.
For a question or two.
Yeah, great talk, Kelly. What is the split between the individuals who come in as volunteers versus through healthcare organizations in terms of sort of ratio or numbers?
In terms of racial numbers?
No, in terms of the number of individuals enrolling, are mostly coming in through healthcare organizations, or is there a growing number of volunteers who
Right, a very appropriate question. So originally, this was launched with our healthcare organization, so that number is by far the majority at the moment. We have had a significant increase in the direct volunteers, and we're hoping to continue to do that. So we have some campaigns that we're launching in cities to be able to try to increase the direct volunteers that we're obtaining, but that is an area that we're definitely working with in the future.
Here's your mic.
Yes, and tell me what is the trajectory? When do you expect for researchers to be able to start looking at and using the data?
So we expect early 2020. So we're hoping to be able to launch this in late this year, if not early next year.
Great, thank you.
Use your mic, please. Can you press down
And
on
with
that?
the one caveat that the data that we're collecting will be obviously rolling. So we will continue to enrolling, and we will also have expanding data as we roll out new surveys as well.
If I understood correctly, you have to finish the surveys before you give in a biospecimen. Does that not increase your healthy volunteer effect further?
So in order to enroll in the study, yes, you have to have done the surveys to be engaged, to be invited to do the biospecimens, yes.
So there is a slightly greater degree of...
Yes.
Yeah.
Yes.
Okay, thank you.
Yes.
Don't you have a high selection bias in terms of social economic status of people?
So we have a wide diversity. Actually, we have over 75% of our populations what we would consider to be underrepresented in biomedical research, and over 50% are what we would consider racial or ethnic minorities in the United States. So we have not looked at socioeconomic status per se yet, but the diversity is really a key priority. And so we've been targeting groups that have been traditionally underrepresented, and we've established community partnerships with organizations that have helped us with recruiting from a wide variety of participants who have not traditionally participated in research previously. Yes.
Hi, I was wondering if you could just give a few more details about your pilot for return of results, how that ties into your scientific strategy, and is that going direct to patients or is it going to healthcare providers, or just some more details of what you're trying out?
Absolutely, and this is clearly one of the things we're working on. And we are working right now, all data is returned to participants, none of it goes to the healthcare organizations itself. Participants will get back their, obviously, physical measurements when they're obtained. In addition, they're getting their survey results back. And what we're working to do is to help them put them into context. So we're thinking through what are the best ways to return that data to participants. And we're working on making sure that it's both ethical and consistent with what our IRB would allow.
So it's a return of the sort of the phenotypic results, not the genotypic results then that you're working on at the moment, or are you planning both?
We haven't done genome sequencing yet. We're rolling out our genomics later this fall, and our expectation is that people will get those results back. We just don't have them available quite yet.
Thank you.
Thank you very much.